Good evening, everybody. My name is Dr. Matthew Holder, and I am the President-elect of the American Academy of Developmental Medicine and Dentistry, and I'm your host tonight for the Physician Education and Developmental Disabilities webinar series, presented in partnership with the Florida Center for Inclusive Communities and sponsored by the United States Department of Health and Human Services Administration on Intellectual and Developmental Disabilities and the Florida Developmental Disabilities Council, Incorporated. Tonight is the 8th installment of our 12-part series, occurring every Tuesday night at 6 p.m. Eastern Time through October 9th. Each of the 12 parts of this series is accredited by the American Academy of Family Physicians for 1 credit hour of AAFP prescribed credit. This is recognized by the AMA as equivalent to 1 hour of AMA Category 1 credit. Archives of each presentation are available about 1 week after the live event at www.aadmd.org. And the archives are accredited for CME credit for the next 2 years. For those of you who are not physicians, you may also use this link to obtain a certificate of completion. Just keep in mind that we are only able to award continuing medical education credit for this webinar series. Toward the end of the presentation tonight, there will be time for questions, as always. So if you have any questions while the presentation is being given, please type them into the question box as you think of them on your control panel. And we will get through as many questions as possible during the time we have left. So tonight's presentation is one that I've been looking forward to for a while because it really exemplifies the orientation that I think healthcare providers should have with respect to patients with intellectual and developmental disabilities. And it is really summed up by the title of the talk, Optimizing Well-Being. As clinicians, this is really the aspiration for all of us. Our job isn't really over when the prescription for antibiotics is done and the patient's temperature has gone away. And it's not over when we've finally found the correct anti-epileptic regimen that manages our patient's seizures effectively. Now, instead, we should continually look for ways to improve the quality of our patients' lives by engaging in health promotion activities, and that's really what we're going to be talking about tonight. So our speakers tonight, we have two, are Dr. Deb Dreyfus and Neela Benito. Dr. Dreyfus is an assistant professor in the Boston University Department of Family Medicine. She went to medical school at Robert Wood Johnson Medical School in New Jersey. Went to her family medicine residency at the University of Wisconsin Department of Family Medicine in Madison, Wisconsin, and obtained a Master's of Science in Epidemiology after residency at Boston University School of Public Health during her academic fellowship. Her interests include providing primary care for children and adults with IDD, transitioning of care from pediatric to adult care physicians, and residency education in the area of intellectual and developmental disabilities. She has presented at several national conventions, topics related to communication, preventive care, and managing behavior changes in adults with IDD, and has written chapters on preventive health and violence in adults with IDD. But our first speaker tonight is Neela Benito, and she is a coordinator of community supports for the Florida Center for Inclusive Communities at the University Center of Excellence in Developmental Disabilities. Neela's primary focus is to help her sons with autism, Vincent and Joseph, be the best that they can be. That's her focus. Through her work at USF, she promotes positive outcomes for and a greater understanding of people with developmental disabilities and their families. Before working at USF, she was a reporter for the Tampa Tribune and director of public relations at Shriners Children's Hospital. In 2004, Neela was appointed as chairperson of the Governor's Blue Ribbon Task Force on Employment, Community Living, and School-to-Work Transition. In 2002, she was elected to a 2-year term as chairperson of the Florida Developmental Disabilities Planning Council and served a 4-year term as a member of the Department of Education's statewide advisory committee. Neela's professional journal publications and primary interests are in public policy, family professional collaboration, inclusion, customized employment, transition, sexual health, and positive behavior supports. So with that introduction, I would like to now turn the presentation over to Neela. Neela, can you hear me?
Yes, I can. Thank you, Matt.
Thank you.
I'm very glad to be here this evening and share this with you, and will do the best I can to keep it brief but very useful and practical as well. The objectives for tonight's webinar is to identify the common unmet healthcare needs of patients with IDDD, acknowledge barriers to medical care, and recognize ways to improve healthcare needs. And I'm going to be talking specifically about some things that relate to my family as well as other families that I interact with. And first, I think it's really important to introduce you to my family. This on the left is Vincent and Joseph, my husband Joe, in 1994, when my sons were diagnosed with autism at 38 months and 25 months. And then the photo on the right is up in the Georgia mountains. This is them today, age 22 and 21. So they're young adults, and we've really gone through our journey and always looked to helping the boys have the best quality of life possible. So I want to share a little bit with you about the beginning when the boys were first diagnosed. I'm sure many of you realize that in 1994 there wasn't the information and awareness about autism and intellectual disabilities like there is today. So I was really seeking and searching for information. One of it was, of course, trying to find hope for their lives, because really there wasn't much information about the possibility of them having a good quality of life. I was looking for some kind of treatment and some real answers. For the people who said they were, quote, autism experts, it didn't seem like, again, they had answers. They had things we can try, maybe this and that, and 40 hours a week, sitting in a room and learning this therapy or that therapy. Nothing seemed to make sense, and nothing seemed to have a scientific evidence behind it. And bottom line was, I want to know who is going to fix this. You know, who is going to help me fix my sons? Because no one had told me that really autism was lifelong. At that point, it hadn't come to me clearly from any source. So what I did was I started reading and doing a lot of my own research, a lot of my own information gathering. I wanted that crystal ball. I wanted some information about adults with autism and what were their lives like, adults with intellectual disabilities, what were their lives like. And because I had asked doctors, I had asked different specialists, you know, what could their life be like? What's, quote, the prognosis? I was stuck in the medical model and, you know, wanted to know what the possibilities were for their lives as adults. And again, no one could give me a straight answer. And then there was a book I had checked out. One of the books I had checked out was from the local library, and it was actually a textbook for social workers. And this was actually about 2 weeks after both boys had been diagnosed. They were diagnosed about a week from each other, because when Vincent was first diagnosed, I realized, uh-oh, I think Joseph also has it, and rushed to get him a diagnosis, and you know, he as well was diagnosed. So this book, this social worker book, had a chapter that was titled The Sexual Needs of the Young Adult with Autism, and I thought, wow, well, that's a crystal ball, if, you know, nothing else is. And the first line of that chapter, I really didn't have to read the whole chapter. The first sentence said, the sexual needs of the young adult with autism is the same as any other young adult. They just don't have a way to fulfill them. Well, that was like a real slap in the face, and it was like, wait a minute. You know, I tried to think of things logically and said, well, if they have the desire, if they have the need, there's got to be a way to figure out how to support them in fulfilling that need. So here were my sons, 2 and 3 years old, and I was already like saying, okay, that's it. I'm going to make sure that when time comes, they are going to know how to fulfill their sexual needs. So I was determined from day one. And then I met someone who was a parent from Kansas who shared with me soon after I had read this about how in puberty, individuals with autism tend to have more challenging and problem behaviors. You know, and I kind of put 2 and 2 together, realizing there was a deficiency of information about how to educate individuals with autism and intellectual disabilities about their sexual health needs, as well as, even though there was some information, no one was doing it. And I started looking at the research, and the research was pretty daunting, and it really gave me another reality check. And it was saying the consequences of not addressing sexual health and sexuality with individuals, that Of course, victims who have some level of intellectual impairment are at the highest risk of abuse. More than 90% of people with developmental disabilities will experience sexual abuse at some point in their lives. 49% of people with intellectual disabilities will experience 10 or more sexually abusive incidents. And then with rape likelihood, 15,000 and 19,000 people with developmental disabilities are raped each year in the United States. I was floored. I was floored by this research. I was floored that this is what is happening in our country and over the sexuality of individuals with intellectual disabilities. So I knew there was something I had to do. I decided I needed a little more information to better understand why this is such a problem, and I found a couple of factors. One is, of course, the individuals with themselves and their disability. So there are these what's called vulnerability factors that the individuals with the more significant the intellectual disability, the more the person is taught to be compliant, and that compliance is reinforced. And the fact is, most of the time they're saying caregivers, and more than likely paid caregivers, are the ones who commit the sexual abuse. So compliance is reinforced. And then there's the need for personal care. So these individuals have little control over who touches their body and in what manner. Isolation. Often individuals are segregated, and they're with people from people without disabilities, so it increases the likelihood of sexual abuse and underreporting. I do know some cases, and the literature is full of these cases, where the individual who's been abused, can't express and in an efficient manner what exactly occurred or necessarily who did it. So they find things unfounded until someone actually witnesses it, who can then say who's committing the actual abuse. And I actually had something similar happen with my son. It wasn't sexual abuse, but it was someone in the middle school who had been shocking him and using a pen that had a little shock to it, and actually told another staff member what she was doing, and someone overheard her talking. And they tried to interview my son, and because he couldn't tell them, even though he'd never wanted to be around this person, he couldn't specifically tell them what she did. They couldn't charge her with anything, and she didn't lose her job. She was just reassigned. So that's just something simple, which of course was very mortifying, but being sexually abused is so much more grave, but it's very serious. So the physical defenselessness, the limited ability, of course it depends on the disability if they are limited in their physical ability. However, a lot of individuals are not taught to defend themselves, and again, because that compliance is reinforced. I shared with you about the language and the vocabulary barriers to be able to say no or to express what it is. The limited cognitive abilities, so they can be easily convinced and manipulated and taught to think this feels good and this is okay and this is right. And then the thing that floors me the most is the lack of abuse prevention education. So because there's this lack of education, the individuals have difficulty or no understanding of recognizing an abusive situation. And one of the things that is taught, by the way, sometimes in schools and in communities is stranger danger, which the problem here is that most often it's someone that they know who is committing these abusive acts. So it's the literature says to teach strange behavior, what strange behavior may be like, whether it's someone you know or don't know. I want to share a little bit more with you about sexuality education and families. Families don't feel comfortable in general. I mean, it's a kind of a taboo subject in our country when there's you have a child without disabilities really being able to talk frankly about it. So no less here you have a child with an intellectual disability where it's even difficult to express it in a way that they may understand. So some of the common reasons, and this is based on research as well, is they have fear that the child, once they have the sexual knowledge, they'd be more likely to experiment. And the underlying hope is, if I keep them like a child, if I don't share this information without them, if they don't know about sex, then they will have no desire to fulfill their sexuality. But the reverse is true. I mean, they do have the need, they do want to experience and express their sexuality. However, if they don't get information, it's going to be done inappropriately, which doesn't always mean it's abuse, but then again, there's a lot of incidents where individuals are arrested. So I'm going to move along kind of quickly here because there's so much to share. They have difficulty, as I mentioned, it's taboo, and they tried, and it failed for whatever reason. So this I wanted just to share with you, this one resource, and it was produced by the Developmental Disabilities Council. One of the basic things is to talk about private and public, but there's this really awesome instruction manual and resource guide that's free for download, or the Developmental Disabilities Council can send it to families or physicians or educators. There's 2 versions. It's also in Spanish, and this is the link for that. Sharing a little bit more with you about addressing the needs of individuals. You know how there's comorbidity, and in my case, with my sons, Joseph had obsessive compulsive disorder in addition to autism, and they had sensory issues that were pretty severe. So I realized that we needed family-centered care. What did that mean to my family? Well, it meant I needed a doctor where the whole family can go and really understand the dynamic, because my husband was in denial for a long time, even though he was loving. So he wasn't very participatory in making decisions and figuring things out. So I realized we needed a family practitioner, not a pediatrician, and that was when the boys were 4 and 5. And then it took me a while to realize that autism is really not a medically based disability. There are some medications you can try depending on this or that, but it's really more about intervention and support from the family and from the community, rather than saying we're going to do this treatment, we're going to take this pill or do this operation. However, very often the services that we try to access, and we need you to say it's medically necessary, or it's medically necessary to have a personal care, that this person, can't be left by themselves, so we can get supports that we need in our home and in the school. So quite often, I needed a physician who could understand the family dynamic and also be willing to validate the need for some services to be medically necessary. And then needed a physician who would be supportive and boost our confidence and my confidence in being the boy's mom. Because I really, until this day, I don't know for sure if I'm doing everything I can do or doing it right. And knowing I have a physician who is by my side and we're sharing knowledge, and they look towards building on my strengths, it helps me cope, because that's pretty challenging. So individuals with intellectual disabilities, I'm sure most of you realize, at least 90% have difficulty with abstract concepts. So it's important for you to be concrete, expect the patient to be involved in their care, always talk directly to the patient, whether they're looking at you or not, whether they're responding to you or not, talk directly to the patient, and if the family member needs to respond, they will. Some supports that you could use in your clinic or your practice, having photos, especially when a patient is a new patient, having photos available either on your website of the physician, of the office, of an exam room. Very brief video clips are awesome to have on YouTube. Just say, hi, I'm Dr. So-and-so, I'm nurse so, whatever it is, and looking forward to seeing you and having you come to my office. And it could just be that brief, to 15 seconds, 20 seconds. Sometimes it's helpful to have like a little schedule or a list of what's going to happen, whether they may have to wait in the waiting room. There's stories that can be created. There's a lot of supports out there about what is a visit like to your clinic, your practice, your office. My sons can't handle very well fluorescent lighting for a prolonged period of time, so sometimes natural lighting is helpful. My son will turn off the lights in the exam room and turn on the X-ray. Even though that's not natural light, it's less light. So we try to work with that. And one key thing, even if you can't see the patient right away, if there's been an emergency or something, try to put them in an exam room where it's quieter and they can relax. The sooner the better. A couple of last things. Remember, please, that the parent is the only constant, and it can be challenging if a parent is in denial, or if they're stuck in the expert model and not realizing that they are the front line, that no one's going to take care of this for them. They need to be the ones in charge. If they don't have confidence in their knowledge or ability, and if there's financial strain, which there always is, that of course makes it more difficult. And one last thing, I don't know if many of you actually read this study, that mothers of children with autism experience the same stress as combat soldiers. So although it seems a lot of it falls on the shoulders of the mom for whatever reason, making sure that they are getting the support and the care that they need to take care of themselves is important as well. This is the last two slides I have. There is some research there about family-centered practices and those that build family confidence and well-being. There's relational family-centered practices, which simply include compassion, active and reflective listening, empathy, and effective communication and sensitivity. So there's that level where you're building a relationship and being kind and compassionate. But in order to really empower, which I kind of hate that word, but in order to empower, I'll say it again, you need to move towards participatory family-centered practice, which is really actively involving the family members to help make decisions and using their strengths and abilities, as well as helping them develop new skills, keep them informed if you receive an article or something. So, you know, again, sharing information, and then being responsive and flexible in how to help and support. So I have to, just in closing, share with you that I am grateful that I chose early on to go to family medicine, because that has created the glue that my family has needed to feel some comfort and some confidence to continue to move forward, knowing that I have a physician who understands our situation in our lives, and then I can call upon them if I need to. It really has made a huge difference in how we function as a family. So I'm going to go ahead and turn it over to Deb, and I thank you for giving me this time to share a little bit about my family.
Thank you very much, Neela. So again, my name is Deborah Dreyfus, and I'm discussing very similar things that Neela discussed, and it'll probably ring very true when I'm talking about some of the things I'm talking about. Again, we're going to review some of the common unmet healthcare needs, acknowledge barriers to medical care, and recognizing ways to improve healthcare needs. So when I'm talking about identifying the common unmet healthcare needs of patients, I've divided this into 5 categories: physical well-being, lifestyle-related health problems, mental health, prevention, and social well-being. Specifically thinking about physical well-being, I brought up 6 different unmet needs that we often see, beginning with seizures. Epilepsy occurs about 15 to 20 times more often in people with intellectual disability than in the general population. Seizures are more likely to be severe, and regularly experiencing seizures may decrease life expectancy by up to 20 years. Obesity is also a concerning unmet healthcare need, and this may be due to behavior and seizure medication side effects, or it may be due to a sedentary or non-ambulatory lifestyle. The increased prevalence of obesity in adults with ID puts adults with ID at increased risk for diabetes, high cholesterol, and hypertension. Gastrointestinal problems are additionally an unmet need, and specifically I'm going to talk about acid reflux and constipation. And in a cross-sectional study, they found evidence of GERD to include hematemesis, rumination, dental erosions, and hand-mouthing when someone puts their whole hand in their mouth. Constipation can also appear as a change in behavior, and without diagnosis can cause ileus. Mobility is an area that's been studied very heavily, and it's been studied so heavily that a systematic review came out looking at the epidemiology of mobility issues. But due to a varying array of documentation, they developed a pooled prevalence of mobility limitations that vary between 3% and 63%. That being said, it's clear that mobility issues are concerning for adults with intellectual disability, and we've seen that decreased mobility is correlated with a decreased life expectancy. Dentists are very aware that oral health is a definite need for adults with ID. Then the Surgeon General's report, adults with ID were noted to have a higher rate of dental caries, periodontal disease, and poor oral hygiene. Untreated dental issues lead to loss of teeth, altered behavior, difficulties eating, and difficulties speaking. When we think about sensory issues, we think about both vision and hearing. Estimates of vision conditions vary from 2% in the mildly disabled to 60% in the profoundly disabled. Hearing problems is also was also evaluated at a Special Olympics sports event, and approximately 24% of hearing loss was revealed, which was 1.4 times greater than seen in the general population of those with similar ages. Most hearing loss was previously undetected, unserved, or undertreated. When I'm talking about lifestyle-related risks, I'm thinking about limited access to sports activities and other activities. These can lead to obesity, constipation, and increased fractures. Sexual health was very well covered by Neela, and recent research is consistent that evidence are less informed about sexual health in the general population. The lowest scores are on the topics of puberty, menstruation, menopause, sexuality, safe sex practices, STDs, and legal aspects of contraception. And this is, the areas of STDs we often look at. And actually, in the British Medical Journal, they discussed a cross-sectional survey finding that STDs were 8 times more common in people with ID than in controls. And Neela also discussed a lot of the research that talks about sexual abuse being higher in adults with intellectual disability. But another area covered by Neela that's striking is the conservative views towards sexual behavior. Due to the lack of sexual education, adults with intellectual disabilities endorse fewer sexual activities, and they have more negative attitudes towards sexual activities compared to those without ID. So that's also an educational limitation of sexual health. Other areas that there are unmet needs include smoking, alcohol, as well as substance abuse. Rates of smoking among people with mild to moderate intellectual disability appear to be similar as to the general population. And while levels of alcohol consumption in people with ID is, on the whole, lower than the general population, alcohol consumption in people with mild ID appears to be the same. And then in a recent study that came out on substance abuse, they stated that while the prevalence of alcohol and access to drugs is low, the risk of having a substance-related problem is very high. So these are all areas that should be screened when you're seeing patients in the clinic. Mental health is an area of unmet need. The prevalence of psychiatric diagnoses is higher. Let me bring this down. Higher than in the general population. That being said, antipsychotic prescription rates are very high. In some studies, almost half of those studied were on an antipsychotic, while a third or less had a psychiatric diagnosis necessitating the use of antipsychotics. So that makes you think one of two things. One, that we are underdiagnosing psychiatric conditions so that it looks like we're overtreating with antipsychotics, which in part is true. Not enough people are seeing psychiatrists and getting diagnoses that they might need. But it's also true that behavior change is often misdiagnosed as a mental health disease, and we might be overtreating with antipsychotic medications. The most common reason for hospitalization in the U.S. are mental health issues, and aggression is a major reason for hospitalization. Prevention is an area of unmet health care needs, and it's prevention in a lot of different areas, but I'm specifically using as examples participation in breast cancer screening and pap smear prevention programs is low, and osteoporosis screening is also an unmet health care need. Social well-being, we often see people with intellectual disabilities that have a higher risk of poverty, they have higher transportation costs, and they have increased stress. So these unmet and untreated areas of health are often lead to barriers in care, which lead to unmet needs. For instance, mobility limitations can lead to difficulty accessing health services. And in a qualitative study looking at physicians who care for adults, or how they care for adults with intellectual disabilities, one physician said, "It took 2.5 people to get the patients in the office, and it really wasn't safe to get them on the exam table because of space issues." Sensory impairment can lead to reduced communication and comprehension of health processes. Behavior problems can lead to difficulties in examination and investigation of disease. For instance, last week we had a patient that had an abscess in his foot, and we were concerned that there was a foreign body in there. We sent the patient to the emergency room so that he could be given sedation so that the foot could be evaluated, because he wouldn't sit still for us to examine him. When he got to the emergency room and he was given benzodiazepines, he was still wide awake and they couldn't take a look at the foot. In the end, they just gave him antibiotics and sent him out because they weren't able to get a closer look at that foot. There's also the limited communication, which is an issue. Patients often will have difficulty in describing their symptoms, which will make it difficult for physicians to diagnose them. There's also the fact that there might be reduced comprehension of health processes. Pair that with poor communicative skills of the health professionals, and it's difficult to manage some of the healthcare problems at home if the only people in the room are the patients and the doctor. Then poor professional knowledge is not an unmet healthcare need of the patient, but it is an unmet healthcare need of the system, and it can lead to attitudinal barriers in accessing care. Now, there have been a lot of qualitative studies looking at how women feel about some of these attitudinal barriers, the poor professional knowledge, and how that poor communication manifests itself in decreased preventive activities. So I talk a little bit about what some of these women have said during these interviews. And many of them had talked about pelvic exams and mammograms being equated with pain and anxiety. As one woman said, "I can't go anywhere because I can't take it. I get too tense doing it." There's a lack of understanding. The interviewer asked, "Do you know what cancer is?" And the individual said no. There's the feeling singled out. One woman interviewed said, "I have a friend who absolutely hated it and stopped going. She was very big. She was, I think, a double or triple D. It really hurt her. And then the technicians really embarrassed her and said, 'Boy, you have large boobs.' Then she stopped going." And so all of these could be mitigated by increased communication, increased education to the patient by the doctor. This goes along with this quote, which talks about lack of preparation. One woman in a focus group said, "Many people with intellectual disabilities don't really understand what a mammogram is about. And if it was explained to them and explained that it's going to hurt, but this is what it's for, maybe it wouldn't be so hard on them." And another woman said, "It's important that I know ahead of time instead of a week later or not knowing at all." So knowing those barriers to care, knowing those unmet needs, the question then becomes, how do we transcend these barriers in order to meet the health needs of adults with intellectual disability? I'm going to talk about interdisciplinary care, encouraging participation in health promotion activities, and formulating health plans utilizing information from multiple sources, including the patient, caretakers, and group home records. So first, what is interdisciplinary care? Well, this is a form of care that emerged in the 1990s. It relates to cooperation between care providers from both the health and social care sectors in order to deliver seamless and continuous care to people with multiple needs. It's collaborative, regular meetings often to discuss patient status and the evolving plan of care. Everyone in the room is at the same hierarchical level, and the outcome of the model is that professionals have skills across different disciplines. So let's look at this a different way. The top picture describes interdisciplinary care. The bottom picture describes multidisciplinary care. In the top picture, you see everyone sitting around the table communicating. They all have smiles on their faces. You might have the primary care physician, nurses, there might be an audiologist there, a dietitian, you might have a physical therapist sitting there, a social worker. And they're all sitting around the table communicating about the patient, collaborating in order to make patient care as effective as possible. And you compare that to multidisciplinary care. Multidisciplinary care is the care that we get used to in the hospital. Say I see a patient and I think that they have depression and they have diabetes. I send the patient to a psychiatrist and I send the patient to the endocrinologist. The psychiatrist diagnoses the patient with depression and puts them on Prozac. Possibly writes a note. I might possibly see the patient, but it's discipline-oriented. The psychiatrist deals specifically with their one discipline. Meanwhile, the patient then sees the endocrinologist who deals with the diabetes, may put the patient on metformin, and then again, I might get a letter, I might not, but the endocrinologist has fulfilled their duties by doing what they needed to do to treat the diabetes that's in their discipline. But there's no communication, there's no collaboration. Let's say I was also dealing with obesity issues, and there was and the psychiatrist wanted to place the person on risperidol, and I was thinking, well, maybe that's not the best medication because of the obesity. There's no communication about that in this multidisciplinary model. I wanted to give you a couple of examples of interdisciplinary care that's going on right now. The first one is one that's on a study that I was reviewing, that I saw online, and it's called the PEACE Pilot Study. PEACE stands for Promoting Effective Advanced Care for Elders. And what this pilot study is doing is it's based out of Ohio. A care manager, a care coordinator identifies a frail elderly in the community, goes to the primary care provider, asks if they can talk to the frail elderly person about goals of care. The primary care provider says okay. The care manager goes to the patient says okay, and discusses what they feel their goals of care should be. The care manager then talks to the primary care provider to make sure that everyone is sure about what the goals of care are at that time. Then the care manager brings these goals of care to an interdisciplinary team. And this interdisciplinary team is made up of a geriatrician, a palliative care specialist, a spiritual advisor, a pharmacist, and a palliative care nurse specialist. And these individuals meet to discuss what the patient would like and also discuss what the standardized protocols are. They make an individualized health plan for the patient that the care manager brings back to the patient. The patient then agrees with the health plan if they're okay with it, and then the care manager brings that to the primary care provider with the patient. They sit together for a visit and discuss what the goals of care will be. And then the care manager meets once a month with the patient to make sure that the goals of care are being met. So this is a subspecialty version of an interdisciplinary care model. The other two I know more explicitly because I'm involved in them. The Boston Community Medical Group is a non-for-profit primary care, nurse practitioner primary care run model of care in the home that allows the nurse practitioners to be the primary care providers under the umbrella of physicians. And then once a week we meet as a team to discuss the care of the patients. Now, also employed by Boston Community Medical Group are physical therapists, social workers, behavioral health specialists. We have pulmonologists and cardiologists that work with us in order to maintain care for patients. And the people who can come go to this meeting on Tuesdays to discuss patients. And the nurse practitioners bring up patients that are concerning, and everyone gives out their level of expertise. And we have nurse practitioners who are confident in wound care management, so they bring in their level of expertise. And if one of these individuals feels like the patient would benefit from them seeing them in the home, then maybe the physical therapist will go with the nurse practitioner to the patient's house to work on improved care. And so this is a truly interdisciplinary model where we meet weekly to make sure that patient care plans are being met. I mean, this is a primary care organization for adults with physical disabilities, but it's a care plan that allows for interdisciplinary care. And then the last one is a pediatric nursing center. And adults with intellectual disability live in the center, but we have quarterly meetings that include the nurse, the primary nurse, the medical team, the teachers, the physical therapists, and the family members. And so this is a interdisciplinary care team that actually involves the family, which I think is fantastic. So a care plan is individualized for that patient for the next 4 months before they meet again. So how can interdisciplinary care be used to improve outcomes? Well, it can be used to reduce fragmentation and discontinuities in medical care, improve patient satisfaction and outcomes, and provide efficient and effective medical care. The question then becomes, does it do this? Yes, in theory, at least for folks with intellectual disabilities. The reason why I say in theory is because there was a study that looked at all the possibilities of integrated care for adults with intellectual disabilities living in the community. And they did a literature search between 1995 and 2003. And they found that although integrated care appears to offer potential for eliminating fragmentation and doing all the things that we want it to do, they didn't find that in the studies that they looked at. Now, the studies that have been published for intellectual disabilities on integrative care include 2 case studies, a descriptive study, and an audit. And in none of these studies did they specifically look for the areas of fragmentation, patient satisfaction, and cost. So it was difficult for them for the people providing the study to see that these were met with integrative care. However, there have been other studies done, not in intellectual disability, that have shown these outcomes. One that I wanted to identify was a study looking at comprehensive pain management programs. And pain management programs are the ones that have really great evidence on interdisciplinary care. This study looked at 108 programs, and they showed that, consistent with other studies, measures of pain, emotional distress, and function all showed significant improvement after 4 weeks of comprehensive interdisciplinary care. And these results held true for 6 months and 1 year samples. And they showed there was increased patient satisfaction. So that area of what we want interdisciplinary care to be was met with this study. But how about increased cost and decreased fragmentation? So to get to those, we look at other studies. One of the studies that was performed was looking at falls preventions in older home care clients, a randomized controlled study. This looked at the number of falls within a 6-month period. And using an interdisciplinary approach to decreasing falls, they actually found that falls within that 6-month period were not decreased. However, they did show that the intervention reduced falls in men with a fear of falling, and they decreased the number of slips and trips. And they looked at the cost of this model of care. They found that cost was increased for the interdisciplinary team. It was increased for the physical therapists and for the people who worked on the interdisciplinary team to try to prevent falls. But costs were decreased in the amount of subspecialty visits that needed to occur. So they ended up seeing that there was really no loss in funds, but there was no gain in funds. It wasn't like this type of care made it more cost effective in this study, but they didn't see any increase in cost either. And there have been several studies that have found that as well. So moving on to encouraging participation in health promotion activities. Interventions that have been studied include interventions in obesity and mobility, which I'm going to put together to be interventions in weight loss. There have been interventions in sexual health, and there have been interventions in tobacco and alcohol prevention programs. So first we're going to review weight loss interventions. There actually have been 3 studies looking at this. One study looked specifically at educational programs. One study looked specifically at physical programs. And one study looked at a group of all sorts of studies. And the areas that they really found that interventions were associated with were behavioral, physical activity interventions, and health promotion. So specifically thinking about behavioral techniques, the ones that were used included teaching self-control, monitoring of food, and this included dividing food into 2 portions and then eating only the smaller portion. It included mindfulness and meditation. It included goal setting, methods to maintain motivation, problem solving, and stimulus control. And they found that there was a loss in weight when they used a behavioral method. Now, they found that the behavioral methods worked better, or they found better improvements in adults in the general population, but they did find improvements in adults with intellectual disability who used these behavioral techniques. When they looked at physical activity interventions, they actually didn't find too much in terms of weight loss. There were some studies that found weight loss, but it wasn't statistically significant. There's actually a study that found a weight gain, and the researchers thought that that was most likely due to muscle mass. But the things that they did find, the things that they studied the most, was how this helped with muscle mass, with resistance training, with balance training. And what they found was that physical activity really did positively affect balance, muscle strength, and quality of life. The type of aerobic activity that was mostly done in all of these studies was walking, although there was bicycle ergometry, resistance training of the upper and lower bodies. There were stepping activities and dancing. But walking was the one that was used the most. And, you know, the things that are really prominent and important for this is that balance is, and when balance is improved, we have decreased falls. And so that's really important. And then quality of life metrics are also pretty exciting. Now, there are 4 studies that looked at quality of life measures, so they weren't able to draw too many conclusions because each study used a different quality of life metric. One study showed an improvement in anxiety. A different study showed an improvement in life satisfaction scores, and a third study showed improvement in self-efficacy. But it's still good that exercise improves quality of life. And then finally, there were a lot of studies that looked at health promotion or education. Now, the study that looked the most at health promotion looked at 12 studies. And 8 out of those 12 studies showed that there was a decrease in body mass index. And some of these decreases in body mass index were actually statistically significant. Some of them weren't, but other positive outcomes that were related to education included decreased health risks, increase in vegetables and fruits, a positive change to the diet, and an increase in exercise and fitness. The other thing that was discovered with these health promotion activities was their discovery of how good usability was. So one study used a pictorial diet sheet, another used 4th grade language, another used visual analogs and lots of pictures in order to gauge how people were doing. They used a lot of hand raising when they were in groups, and they found that that was really helpful. So this study really said, okay, these are really great interventions to use if you're trying to do an education intervention. And the last thing that a lot of the studies discussed was carer involvement. So they found that while carers being involved didn't help with increasing the activity of folks with intellectual disabilities, they did find that if carers were not involved in the exercise process or in any of these modalities or interventions, then patients dropped out. So they found that it was important to have carers being involved. I wanted to specifically talk about one of the intervention programs that was discussed, the Take 5 weight loss intervention program. And the reason why was because of all those studies, when they discussed behavior interventions and physical activity interventions and nutrition and educational interventions, while all of them were okay on their own, together they were so much better. So this is a study that looked at taking all of those factors and putting them together. Take 5 weight loss intervention program is an intervention program that was adapted from an intervention program that's for the general population. And they actually had an interdisciplinary group of specialists come in to adapt this for folks with intellectual disabilities. They made sure that the intervention involved family or paid caregivers. They made sure that the diet consisted of an energy deficient diet. They used diets that were 600 kilocalories per day. They made sure that adults were doing exercise, and they recommended 30 minutes per day for 5 days in a week, and they could do it at 10-minute block intervals at a time. And they found that significant changes occurred in the body weight and weight circumference. They also found that there were changes to level of sedentary behavior and light intensity physical activity. What that means is that by the end of the study, people were sedentary a lot less, and people were doing light intensity physical activity a lot more. And they also found that there was a low dropout rate. The other reason I wanted to talk about this study is because they had a qualitative component to it. So after the study was over, they then talked to the carers to find out what they thought of how the study went. So the carers talked about being facilitators in the care plan and what that was like. One of the family carers said the small team, would build up a routine with Anne, so therefore Anne would get used to going out on X day with so-and-so. And they found that this individual lost weight. They also talked about barriers in the care plan. For instance, one of the carers who didn't, one of the paid caregivers said, we tried to follow the guidelines, but again, it's the constancy. It has to be it's the consistency. It has to be everybody. And this person didn't actually lose any weight. Then this third quote is actually from a family carer. She said, I've got a very busy life as well. My mom passed away as well, and my dad wasn't well either, so it's quite a busy household. My husband, my kids, myself. I've got a daughter in care, so I find it quite hard. But in fact, this person actually did lose weight. They also talked about barriers within the belief system. One of the carers stated, some carers saying, well, she's an adult, so she's got a choice. We've got to help her still give her choices, but help her make healthier choices. So what this carer was saying was that there were some individuals that cared for this adult who said, gosh, if she wants to make choices that would make her gain weight, isn't that her choice? Isn't that her right to do? And what this carer was saying was, we got to help her make the good choices. We have to help her with the healthier choices. And this individual did lose weight. And then one of the paid carers talked about how the level of intellectual disability was important. The person said she doesn't understand the contents of food and portioning. She doesn't understand a small loaf shouldn't just last a day. And this individual did not lose weight. So also talking about interventions on sexual health, and these have been studied. They've looked at educational and support activities in the literature, and they found that adults who have education programs do learn more about sexual education. And in fact, a randomized controlled trial in 2005 showed that those who were in a decision-making curriculum to empower women to resist sexual abuse showed improvements in knowledge, decision-making, and empowerment. And so these educational activities really do help. There was another study that was a computer-based intervention to teach women how to not get HIV. And they talked about how to put on condoms. They gave pictures with arrows to point to different areas of the body. They recommended demanding that the male put on condoms as opposed to negotiating with the male, because they found that the negotiation doesn't really work. And they did find that by the end of this program, women were more educated about sexual health. And then finally, another intervention for sexual health includes things that physicians can do, including immunizations, giving adults with intellectual disability the HPV vaccine, making sure that they're vaccinated against hepatitis B. These are things that we can do to help with sexual health. There have also been interventions looking for tobacco and alcohol prevention. So in a systematic review that was performed, there were 9 studies that were evaluated. There were 2 that were on both alcohol and tobacco, and then the rest were either on tobacco or alcohol. And what the authors concluded was it was difficult to draw conclusions from these studies. The studies there was only one randomized controlled trial, there were a lot of case studies, there were a lot of audits, and they found it difficult to really draw significant conclusions from the studies. However, if you look specifically at the studies and not at the general systematic review article, you find that in each of the interventions, education was increased. And while the reviewers of the systematic review article were unhappy with the outcome measures that were used because they weren't validated or given reliability for adults with intellectual disability, most of those studied showed that people who were smoking were reducing their smoking or were quitting. And those who were drinking alcohol, there was one study that showed a lot more who were in the active stage of contemplation than in the pre-contemplative stage at the beginning of the study. The authors do want to mention that in that study where there were more active people who wanted to quit drinking, they were in an alcohol treatment program. But the one thing that they did want to mention was that the good thing was what these interventions did. And so they said that the fact that the interventions used pictures, they used quizzes, they did role plays, they used incentives, all of these were really good measures and things that should be used in the future to help come up with a really great intervention for tobacco and alcohol prevention. So the final way to improve healthcare needs that I want to discuss is the utilization of health plans and screens. So there was a systematic review that looked at the impact of health checks for people with intellectual disabilities. They looked at 38 publications. This is more than 5,000 people that were evaluated based on this systematic review. And they found that in vision testing, the odds ratio for having vision testing if you were using a health plan was 0.2 times as likely than if you weren't using a health plan. Vision testing, the odds ratio, well, hearing testing, the odds ratio was 10.8. Hearing loss was identified with an odds ratio of 12.6. So adults were more identified if they had a health plan than if they didn't. And then those who received hepatitis B vaccine, odds ratio was 8.5. And then Tdap, to receive a Tdap, those that had an odds ratio of 3.8. So the question then becomes, what are health plans? So health plans are tools that have been designed to prompt a comprehensive health assessment for adults with intellectual disabilities. Health checks, and so I'm going to be using the Comprehensive Health Assessment Program, which is a tool used in Australia to kind of show you what these health plans consist of. So on one of the first pages, you have the person with intellectual disability have their name written down, the family members and the support staff, and then the general practitioners. And it tells you what you're supposed to do. The family members and the person fill out the form and then give it to the primary care provider. And the primary care provider looks through it and then adds to it to be able to develop an action plan. It also describes why the health plan is being given. And so it says people with intellectual disabilities generally have poor health. So it helps explain to the primary care provider why this is being done. Here we have the person's medical history, and then we have where they can write down what the family medical history is. And this specifically is asking about conditions that are more prominent in individuals with intellectual disability, and also areas of unmet healthcare need, like breast cancer, decreased amount of mammography being given, so they want to make sure that there's no family history. And then making sure that any concerns that people have about a person's health are listed on the form. So if the person who comes with the patient to the doctor's office isn't the person that knows them the best, you still have a list of the concerns that you have about the patient's health. On this page, you have all of those unmet healthcare needs that we were talking about at the beginning, so that if the primary care provider is not does not know about what they need to be checking for adults with intellectual disability, well, here you have a list of those. So it helps the primary care provider know what they should be checking for. Here you have new findings that are noted on exam, as well as if there are any mental health issues or concerns. And here you develop the action plan that you're going to be doing to work on those concerns that the providers or that the patient had at the beginning of the visit. Now, the reason why I like that is because that's a health plan that's been studied, and it's been studied in a randomized control study. And using this study, what they found was that there was increased health promotion and disease prevention. They found that the risk ratio for pap smears was 7.9. So adults who used this health plan were had 7.9 times the risk of having a pap smear than if they hadn't had the comprehensive health assessment. Those who were for mammography, the risk ratio was 3.5, and investigation for osteoporosis was 3.7. So in conclusion, there are a number of unmet healthcare needs included in physical, lifestyle, mental health, and prevention and social unmet healthcare needs. There are barriers to care that can lead to these unmet healthcare needs and can make things more difficult. And then we can decrease barriers to care by providing care in interdisciplinary manners, encouraging participation in health promotion activities, and performing annual health plans and assessments.
All right. Thank you, Deb. Thank you very much. That was a great presentation. We do have a number of questions, and I'm sorry our earlier speaker, Neela, had to go and leave early, so we won't be able to ask any questions of her, unfortunately, tonight. But we do have a number of questions, and also anybody, if you have some questions, please feel free to ask them. Deb, I know we did have a lot of questions about references, and I know you happen to come very prepared with references. So one question was if you could let us know the authors of the study on integrated care. I don't know if you can, if you have that in your list, and maybe it might be a good idea just to scroll through some of the references that you have. I know a lot of people were interested in those.
Okay, and I can find that pretty quick. I have all of those articles just sitting here waiting for those questions to be asked. So
this is what it means to be data-driven.
While I find that, are there any other questions?
We had a couple of other questions. Let's see. One was interested in your opinion about prostate exams. So it's a little bit off subject, but you know, in what you thought about the prostate exam and if that was something that we need to be doing.
So that is a fabulous question, and I am so happy you asked that because I just spent a lot of time working on a qualitative study looking at prostate cancer and doing studies on that. Now, the U.S. Preventive Task Force at this point doesn't even recommend that we need to be screening for prostate cancer. So when we think about what the U.S. Preventive Task Force tells us, well, no, we don't need to be screening all that often. But what the other cancer services tell us and what the U.S. Preventive Task Force says in their body of their literature as opposed to in their big, in their one-liner about what we should be doing, is they say if we're concerned about an increased risk for prostate cancer, well, then we need to really be taking that into effect. And there needs to be a lot of shared decision-making about the process. Now, adults with intellectual disability, from what I understand from previous research, actually have a decreased risk of prostate cancer, but that might also be because they haven't been studied as much. Well, all of that being said, I think that the best thing to do at this point, my own opinion, is that it really needs to be a shared decision between the individual, the families, and the doctor, where it's mentioned, gosh, you know, we have these studies. They basically tell us that people of low risk, if we do this test, we may get a high value for our PSA, which might not mean anything, and then we subject you to all these tests, and to test is to treat, and the question is, down the line, would you want to have your prostate removed, which might cause all of these other problems? And if that's not something that you want, then we probably shouldn't even do the prostate cancer test. But if it's something that you're thinking you might like, then maybe we should. And so having that shared decision between the family members and the physician is probably the best way to go.
All right. Thanks. A wonderful answer. Another question we have is probably more of a personal opinion, I guess, is about the use of sunscreen. And it's funny because this issue is one that came up actually recently in a neighboring state of mine. But the question was about sunscreen, and the question really is, should, and I believe this is coming from somebody in the, I'm guessing, a group home setting or ICF setting, should the application of sunscreen require a prescription? I thought that was an interesting question.
That is an interesting question. Personally, I don't necessarily, I mean, I would think that the, the care provider could probably identify when sunscreen should be placed, but it decreases any sort of confusion that you have about whether or not you should place sunscreen. I know that there are some group homes where the carer doesn't want to try to make any medical decisions on anyone. They don't want to have to be placed into that role. And if you have a carer who feels that way, then it helps to have a prescription, because then you have a set reason to put on sunscreen. And I know it's kind of what we do. I'm not sure how necessary it is. I guess it also depends on how comfortable the group home is and what the restrictions are to that group home.
Yeah, this is something I've seen pop up occasionally, just in different states, and I found it kind of puzzling. I guess I agree with you, Deb. I don't really think that prescription is really necessary for a sunscreen, although I understand why some organizations might need it. But I think when you're talking about you take it in context with the self-determination movement and inclusion and those kinds of things, this is being able to purchase and apply sunscreen is kind of a general right that is enjoyed by everybody else in the community. So it's I think at least my personal opinion on it is I don't really think we need it, unless it's there's no way the person can apply it themselves for whatever reason, and you want to make sure that it's being applied properly or something, maybe, I guess. But so maybe I could see there might be some rules that, as you described, but I think in general, for the most part, I don't think it's a necessary thing. Another question was about the weight loss interventions that you had been talking about, I think, early on. Mm-hmm. And the question, well, there's kind of a two-parter. Was there a difference? I think this is when you were talking about some of the behavioral interventions, like having people allocate half of their plate, or and can take the other half home, or that kind of thing. Was there a difference between those behavioral interventions?
So yes, there was, and since it was a review article, I didn't go into depth about which ones were more helpful than others. I also think it's difficult to say if they were more helpful because it was a more helpful behavioral intervention or because of the way it was done. I do know that that specific intervention of dividing the food in half and having the individual eat the smaller one was a successful intervention, which is why I mentioned it.
Okay. I like the sound of that one. I know, in my role at Special Olympics, we often talk about portion size as when we do a dietary counseling and that kind of thing as a fairly effective thing. I hadn't heard of that particular method, but it makes a lot of sense, and I know that it's definitely an important issue. And the follow-up to that, which I think is sort of correlated, is do there need to be interventions, that would vary based on the neurodevelopmental diagnosis? And the person specifically mentioned Prader-Willi versus Down syndrome versus other syndromes. Is there a behavioral approach or a different approach, I guess, that you would?
So actually, it's like you read one of the articles. One of the review articles specifically looked at studies that were related to Down syndrome and studies that were related to Prader-Willi. And actually, what I thought was really interesting was that with the Prader-Willi studies, they found that if they controlled behavior with antipsychotics, people actually lost weight. So in folks with Prader-Willi, they actually found that folks who were started on risperidol lost weight because they were their behavior was more controlled, and they were able to control their appetites a little bit better, which I thought was very interesting. Now, most of the studies that I talked about included a lot of studies with adults with Down syndrome. And they also mentioned that adults with Down syndrome did lose weight based on the interventions reported. So while I clumped it all together, what I talked about really was shown to be successful for adults with Down syndrome.
Okay, great. Let's see, a couple of comments. One was about the possibility of diagnostic overshadowing in relation to sensory impairment. I just made a note of that. I think the comment really, and this sort of comes from something that we've also seen in Special Olympics, but oftentimes in the employment sector, a lot of times, or education sector, people are quick to blame, once they know somebody has intellectual disability, they are quick to blame their maybe learning difficulties or task difficulties at work on the intellectual disability, whereas it may be a vision, as you mentioned, Debbie, a vision or a hearing impairment of some kind that's really being part, really exacerbating the issue, I guess. So that it was just a comment about that, just to make sure that we noted that that can actually be something that diagnostic overshadowing is something that we see even with sensory impairment and intellectual disability.
Yes.
Another question for you, Deb, was about integrative care when you were talking about that and cost effectiveness. And I guess they just wanted clarification. Is for people with intellectual and developmental disabilities or the care of, were there studies that directly looked at cost effectiveness in integrative care to that, or interdisciplinary care to that patient population?
No,
and
that's,
so was it cost effective, or is the jury still out on that?
So I have the name, I have the author and the journal of that study. It's called Towards Improving Medical Care in People with Intellectual Disabilities Living in the Community, Possibilities of Integrated Care. The authors are D.E.M.C. Jansen, B. Kroll, G.W. Gruthoff, and D. Post. It is in my list of references. It's from the Journal of Applied Research in Intellectual Disabilities. And they found 4 studies, at least in 2006, and none of the studies looked at cost effectiveness. So they weren't able, that's why they weren't able to say one way or the other if that was improved in adults with intellectual disability, because those studies didn't look at it. And when I did my literature review, I couldn't find any articles from 2006 on intellectual disabilities.
Okay, great. For those of you in the audience here, we're going to have these PowerPoint slides all available. So the list of references are available in the section, the web link where you go to get your certificate of completion. One last question was about the Australian health plan that you showed. Is there a web link, or how can people get information about that? Is that also in the references?
That's in the references. If you, I actually emailed the person who puts it out in Australia to ask if I could use those slides because, there's a cost associated with it. And they were very excited because they were excited about having people in the U.S. know about this method of care. It's $10 per person per month. And it is available online. If you even look up CHAP, the comprehensive, what it stands for, on the slide, you will get to an email address, and I just emailed that person who was on the website and was able to find out more about buying those or getting information on it.
All right, great. Thank you very much. And would you mind putting on the last slide for me, the one with
yes.
For those of you who have watched more than one of these, you probably have this memorized by now, but I just want to go through it with everybody. If you would like to get your CME certificate for credit tonight, go to the link shown, that's bit.ly.com/PEDD2012. All you have to do is sign in or register if you are not registered. If you are going to register, you should receive an automatically generated email confirmation that you are into the system. If you don't receive it, check your spam folder because it might be there. If you have any other issues as you're going through the system, getting registered, or trying to log on, or trying to viewing, if you have issues at all, just go to www.aadmd.org and hit the contact us button, and it will send an email to one of us, and we'll do what we can to help you through the process. From that website, you can complete the survey about tonight's webinar. You can also take our quiz. Remember that passing the quiz requires a score of 7 out of 10, and then from there the certificate will be displayed on the screen and emailed to you automatically. So with that, I would like to thank all of you for attending tonight's